Okay, so today we're going to be talking a little bit about co-occurring substance use disorder with psychotic disorders. And just quickly, the rationale for this is that folks with substance use disorder is going to be the most common comorbid factor with people that have serious mental illness. And so it's going to either frequently be a precipitating or perpetuating factor in psychosis. So we want to make sure that we're including that as part of our case formulation for folks that are have this co-occurring disorder. So the research shows that about half of the folks that you see are going to have some kind of a substance use disorder that's co-occurring. So it's important that we're addressing that. And the way that we used to address substance use disorder and mental health disorders is that we would take a parallel approach. The recommendations beginning in around 2006 with tip 42 is that we actually are addressing comorbid substance use and psychotic disorder together. And that it's best if we have one clinician that's providing some sort of an integrated approach wherever possible, so that we're addressing them simultaneously rather than as a parallel approach or as a sequential approach. So the key elements that we're going to be talking about here in terms of what we can use or include with our work around CBT for psychosis are going to be how we mix in some motivational interviewing and then, where possible, family interventions as well. So that's what we'll be talking about today. All right, so just to start out our discussion about this, let's just talk about the drugs of abuse that are most commonly related to psychosis, either as a precipitant or as a perpetuating factor. These are probably fairly obvious to you working in the field, but methamphetamine and cocaine are obviously two of the major offenders given the way that they affect dopamine. But also cannabis is also a big precipitator and also perpetuator of psychosis as well. Psychedelics often kind of kick off the disorder, although that they're not typically drugs that are abused long-term, but they can often start a psychosis. And then two other drugs to be aware of will be alcohol and benzodiazepines. So often benzodiazepines or alcohol are used. They're not necessarily perpetuators, but when a person becomes dependent upon those substances, then withdrawal can actually be a major precipitator or perpetuator of psychosis. So there's some other drugs that we should be aware of as well. So with these particular drugs, since they are so often related to psychosis, it's a good idea to be familiar with these drugs, to be asking questions about whether our clients are using these drugs, and also to have a little bit of an idea in terms of what the symptoms of acute intoxication are, as well as the withdrawal profiles around these as well. All right, so it's important that we're talking about this with our clients, right? Because a lot of our clients are going to be facing this issue. And so it's a complicated thing to address. And we may not make too much progress with our client, but we know that if we're not talking about it, then there's no chance that we are going to be able to have any impact here. So it's important that we're keeping substance use we're not putting it totally on the back burner, that it's something that we're considering as we're moving along in terms of making sure that we're talking about it during case conceptualization, during the assessment phase. And making sure that it's part of the psychoeducation that we're offering to the client, especially if we know that they have a substance use history. We should also be casting a wide net around this. Once again, if we're not asking questions, then we're not going to know. And there's two things to keep in mind around substance use disorder and how it's impacting our client, and that is that, first of all, given the fact that our clients already have significant impairment and distress just simply through their mental health symptoms, through the psychosis, often the impairment and distress that they're suffering because of their substance use disorder kind of gets masked a little bit. So we want to make sure, once again, that we're trying to sort this out as much as possible and that we're not missing important pieces because we're not asking questions about it, we're not aware of it. And then the other thing to consider is that because the folks that we're working with already have pretty significant dysregulation to their nervous system, that adding substances on top of that actually significantly, it's the proportion to which a person is affected with psychosis is going to be magnified, right? So with our clients, a little bit goes a long way. So a couple of beers for our clients is going to impact them probably a lot more than a person that doesn't already have some of these kinds of issues. So even though our clients might be reporting that they're using not as much of substances as maybe we would be concerned with the general population, we should be concerned with any sort of use with our clients that have psychotic disorder. We want to be talking about this early, and where it's applicable, we want to be talking about it often. So I would suggest that even with all of your clients that you're including this as part of the discussion where it doesn't seem like that it's going to be that much of an impact on our clients, we can let it go. But where it's going to be applicable, we should be persistent in our efforts to be including this in what we're as part of our treatment. So often our clients are going to have some type of they might be already getting some substance abuse treatment from somebody either in your same offices, or they're getting it from another clinic. So where that's occurring, we just want to make sure that we're on the same page with whoever it is that's offering substance use, if that's possible, so that you're kind of on the same page together. And to try to integrate your approach as much as possible. So integration is kind of the name of the game here. The more integrated that we can be in providing sort of that integrated approach, we'll get better outcomes. All right, so let's talk a little bit about what we can be doing in session with our clients. So, we're not going to be switching to, where our clients has a substance use or co-occurring disorder, we're not going to be, just totally switching over to substance abuse treatment, obviously. So we don't, we want to be able to weave in some of these kinds of interventions without necessarily making that the entire focus. And one way that we can do that is to consider, motivational interviewing moments or motivational enhancement to our sessions. So that would be just brief 10 to 15 minutes where we're discussing and exploring with the clients the three aspects of change. And so that would be the desire to change or wanting to change, self-efficacy, so that if you wanted to make a change, you feel like that you could, and then commitment to change, and that would be sort of the concrete plan that the person has in place, so that they're going to be doing X, Y, and Z. So a lot of you, probably most of you, have been trained in motivational interviewing, so you can start incorporating that into your sessions, just from what you've learned, and feel free to do that in terms of using your good clinical skills, in terms of your ORs and rolling with resistance and some of those other kinds of principles, which we will talk about more specifically when we talk about motivational enhancement theory in a couple of sessions from today. Okay, so there's a lot of motivational enhancement techniques that we can use. You can use rulers, or you can use, they have those great motivational interviewing values cards that you can be using with your clients. But one of the things that I think is really great in facilitating these motivational moments is using a payoff matrix. And a payoff matrix is a way of exploring ambivalence, reasons to be using and reasons not to be using with your client. So with a payoff matrix, one thing to keep in mind is that we want to be facilitating change talk. So that's the client listening to themselves talking about making change. And so it's important that we consider, using the payoff matrix in a way that's going to facilitate change talk. So we want them to end up either with change talk or commitment talk at the end of using the payoff matrix. So the way that we can do that is we can start out with talking about the advantages of substance use. And so that we can so that we're not provoking resistance, and that the client is able to talk about that side of the ambivalence, and then work towards talking about the advantages of using substances. So this is the way that I would recommend that you do it, that you start out with talking about the advantages of using substance use, and then you can move to the disadvantages of using substances, and then back to the disadvantages of not using substances. And then finally, you can end the conversation with talking about the advantages of not using substances. So I provided you with some common examples of why people use substances or why they don't use substances that might be helpful for you, and these come from Kim User's manual on integrated dual diagnosis treatment. And if you want a further resource, then that's a great book in terms of offering an integrated approach. All right, and then the other thing to consider is family education. So specifically, where we have clients that have good family support, we want to make sure that we're including the family with family education, and this makes a huge impact with our clients. If we can draw the family in, provide them education and support, then it does it can be really great in terms of working with the clients around this. Often it seems, with our families that we've done a pretty good job, I think, in general, of working with some of the stigma that's around the mental health symptoms, but often the substance use side gets a little bit short-thrifted in terms of talking to families about it and helping them understand why people are using substances and the commonness of our clients using, and also some of the things that they can look for and some of the ways that they can help support their family member. So the educational topics that we can use is we can talk about the reasons why clients use. We can talk about what the criteria are for substance abuse disorder. We can provide a little psychoeducation, as I have today, in terms of the impact that it has on the clients and the reason for that. And we can talk about the stress vulnerability model in terms of that substance use is a primary stressor or primary factor in terms of exacerbating symptoms. And then where it seems appropriate, we can talk a little bit about the pharmacological criteria of tolerance and withdrawal, if that's something that that you feel like that you have some knowledge about or some expertise to share. And then finally, we can wrap this up by talking a little bit about contingency strategies. So contingency strategies, typically these are ways of providing positive reinforcement for participation. When it's done formally, we normally do this within a group context where we have kind of a lottery that we're using, where clients can pick out from a hat or something like that different prizes, and then one prize is going to be like proportionately more expensive or desirable than some of the other ones, so that we're trying to trigger the reward circuit so we can be providing reinforcement for them to continue participating in treatment. If you want to, maybe you could try to, or if you have the resources, you could try to set up something like that. But typically speaking, with contingency strategies in individual therapy, we're really thinking about how we can provide positive reinforcement through praise, through making sure that we're talking about a preferred topic, and offering that as a reward to the client, or by playing a game or having a similar reinforcer where we're really consistently reinforcing the behavior of participating in treatment.